expanded because of that. So there, like Bauman said, you know, he's doing it secondarily, but I do it primarily. So I alter the affected soft triangle at that time. So I think doing it through an open approach is more precise.
We want to thank the panelists very much. In the interest of time, we're going to move on to the palette group. Please come down and sit at the table so that we can move along quickly. Appreciate it. Our first speaker in this group will be Dr. Hoffman from UCSF, who will be speaking about palatoplasty tips and tricks.
Good morning. When I got this assignment as a talk, I was reflecting on the fact that this is a topic you get to the old guy. Not necessarily the oldest guy, but close. In any case, this is actually just sort of a technique talk. I think for the people on the faculty, this is going to be redundant or contradictory to what you do, and that's fine. What do I have? So this is just things that I do when I'm doing cleft palate repair. So I'm going to talk about ergonomics and equipment technique, and also some stuff that I do at the end that some people would consider controversial or not necessary, tongue sutures and ice packs. So the first thing is the setup. This is a picture of how we set it up in the operating room. At our New Children's Hospital, our operating rooms are like the size of handball courts, which is nice, but it's we don't really need all that space to do this. But I like to put the table pretty far down and not have my arms, hunching my shoulders up to it, because I think in the end it helps to make it be more comfortable. The Dingman's hanging off the Mayo. All the instruments are out. All the sutures are loaded, so that and I'm fortunate having the same team most of the time, so that they are familiar with this. I think it's important to remember about the Dingman, that I emphasize that you have to talk to your anesthesia colleagues. Sometimes it'll obstruct the tube, and you realize the anesthesia resident is fiddling around with stuff, and you've obstructed the airway with the Dingman, especially in an older patient that has teeth, where the Dingman can push the tube against the teeth. Also watch the time. 2 hours of Dingman time will give you a lot of tongue swelling, or over 2 hours anyway, will give you a lot of tongue swelling. I don't go over 2 hours ever, but it certainly has happened with some people. Just a thing about instruments, I really love this needle holder. This is I don't even know what it's called. It's in the OR, it's called Dr. Hoffman's curved needle holder. And it has a fine tip that you could the tip is like smaller than a Webster needle holder, but it's 7 inches long and has this curved tip, and it makes it really easy to suture inside the mouth. And actually for when I used to do more head and neck micro reconstruction before our ENT colleagues hired their own people, I would always, my go-to thing is to get the cleft palate set to repair anything inside the mouth. It makes it much easier to see if you have a curved needle holder, because straight needle holders are blocking your view of what you're doing. Same thing with forceps. These sort of very long, modified Brown Adsons give you a nice grip and don't tear anything. This is just the basics. I call them long browns. I actually don't know what those are called either. These are things that have been on this set for 30 years, and they find new ones, but I still don't know what they're called. So sutures, I like soft sutures. I think Chromic pokes kids in the mouth, in the tongue, and doesn't. But this curved needle hold, this needle that is, I have no disclosures, by the way, and I have no interest in Ethicon particularly, but this needle is unique and is this sort of J-shaped needle that, particularly in the hard palate, when you put the suture in, it starts coming out just as you guide it through, and it makes it incredibly easy to get the sutures through. And if you put mineral oil on the sutures, it makes them tie like silk, which is nice. So there's no binding. That's just a close-up of what the needle looks like. It's an unusual shape, but it's super handy. The other needle I really like a lot is this tiny little needle. Unfortunately, you don't need it to be double-armed. This is only 8 millimeters in diameter, and in the nasal mucosa, when you're in a tight spot, doing like the vomer flap, you know, that can be very useful. It's also really useful when you do alveolar bone grafts for the nasal floor, where you have a tight space and it's hard to get anything else in there. And just technical tips. I make the residents practice this, but I switch hands. I stand in the same place, or the resident stands in the same place, so that when you, and I'll talk about this in a second some more, but I think it's important that you actually switch hands for the different sides of the palate. And I'll talk some more about the pedicle. I think once you get the muscle elevated a little bit, the levator muscle, actually you can take a periosteal elevator and dissect it all the way back to the lateral wall really quickly. And there's a nice, if you're in the right plane, it just comes up easily and is less likely to tear the nasal mucosa. Everyone agrees on releasing the tensor tendon, I think, and overlapping the muscle. And I think using mattress sutures, particularly in the hard palate, has been useful. I've seen a lot of my older kids come back and they have this groove in the hard palate, and you can't tell if there's a fistula or not. Hopefully not. But if you do mattress sutures at the time of the initial repair, you get a nice smooth hard palate, and it's much easier to work on later, actually, when you come back to do the bone graft and stuff. This just shows a view of my resident working. So the knife is in his left hand, and he's doing the incision that's along the alveolar ridge on the patient's right side. So that when you switch side, when you're aiming, if you use your right hand on the right side, your natural tendency is to be at an angle where you're likely to cut the pedicle, and that's obviously something we want to avoid. Where if you switch hands, you don't have to move, and it makes it much easier. They hate that, you know, everybody hates, like, because for years everybody's told them, don't use your left hand, don't use your left hand. But, or if you're left-handed, then, you know, I mean, either way, but you use your right hand for the left side, your left hand for the right side. Same thing with the periosteal elevator. When you're elevating the left side, I use my left hand to elevate the left side. Just switching off makes it much easier, but it's not inherently obvious to residents that should happen. Dissecting the pedicle out. This is from Dr. Edgerton's paper from 1962, where he talked about elongating the pedicle. He was talking about it in terms of using it for pushback, which I would not recommend, but this is a diagram. This is not from that paper, but this is from the paper. It shows the dissection. It's important to get this whole thing released here. There's a periosteal attachment of the flap to the hard palate behind the pedicle, and it's where I actually usually bovie this little area here, and you're like 2 or 3 millimeters from the pedicle, so you got to be careful. And then what the residents all call my attending move is where you take like a tenotomy scissors and spread in there, and the pedicle comes up out of the hole, and it actually really does make it so that you can have a tension-free closure in the